Yvonne, she's a hematology clinical nurse specialist, EIS and St. Thomas NHS Foundation, and he have a vast experience and more than 20 years in this field.
Thank you very much. And it's great to be invited back. Thank you very much. So I'm here to talk about the psychosocial impact. I'm really pleased actually because a lot of the lectures that you've had before me have done a lot of the hard and they've given you the facts and the figures and they've talked through a lot of the main people have, which means that I can crack on really on this lecture and not have to give you any facts and figures, but try and give you an example of the used to help people cope with these issues, okay? I'm just going to very briefly sort of the role of the nurse and the impact on patients, and then I've used a few current patients and I've used them as case studies just to try how we're guiding them through at the moment. So while information for this, I came across this. Now it is Crohn's and colitis, so thank you very much to them. But again, it's a good sort of illustration again of the path to the new normal that people go through at the diagnosis, and we've seen a couple of other people's kind of idea can picture these as well. But personally, I thought this was the feeling of falling that was mentioned before, the stages of grief to acceptance, up set of stairs. Each stair is a different stage to go through, a different issue to cover, and your new normal. It will never go back to being the original, but it's a new normal. That at some stage in your new normal, something else is going to happen. And then you're going to go through this climbing of the ladder to the next level of normal. So it's almost like it's a cycle, really. We tend to use a multidisciplinary approach to care. So while I'm sitting here telling you how wonderful nurses are, you do have to remember that we are a part of a team, okay, us. And one of our roles as nurses really are to try and pull together all these parts of the team, look at the patient and the carer. Who do they need? What can we do best? We can't do everything ourselves. We're not psychologists. We're not experts in certain things. But what we can do is signpost them and pull all our multidisciplinary team together to give this person and their carer the best example. So, for example, we are very lucky at Guy's. We have a comprehensive cancer centre. We have a very good multidisciplinary team, and we can pull from a lot of different experts to provide the patient and the carer with the support they need, including our physiotherapy and occupational department in our cancer centre. They run a very comprehensive fatigue programme, and they're going to start a sleep programme as well for patients. And we also have a Dimbleby Cancer Centre as well, and they can provide financial support services, complementary therapies, and they've got quite a good support programme for carers running as well. So this is just examples of who we can pull in to help. So the relationship between the nurse, the patient and the caregiver. So the CNS or the nurse, I don't know why there's a question mark there, sorry. But we interact between the patient and the caregiver. And I think what's really important here to mention is that sometimes it's only us and the patient because they haven't brought that caregiver or they don't want the caregiver involved. And therefore, we can't get involved there. Other times the patient might have a caregiver with them, but they have not given us permission to talk to that caregiver. And we can only tell a caregiver as much about our patient's condition as the patient lets us. We have our rules of confidentiality here. So we have to bear that in mind. It's quite difficult to handle sometimes, but that's where we are. Okay, just quite an important point there. So our main role, well, obviously we there to try and develop a very strong relationship with the patient and we're safeguarding their interests and well-being, at the same time respecting and valuing their freedom and their self-determination and trying to help them through this whole decision-making, going up those stairs to find their new normal process. And also sharing the information and giving them as much information as you possibly can to empower them to make their own decisions, and that also includes the caregiver as well. And hopefully they'll be making those decisions together as opposed to just one of them. For those of you that are not lucky enough to have clinical nurse specialists, we have quite a big role in the care of patients. Not like in my grandmother's day where we just folded up bandages and mopped the fever's brow. We're a lot more advanced now, really. Most of us have, well, not most of us, but a lot of us have advanced assessment skills. We have our own clinics, and I'm talking for myself and my colleague Claire Woodley at Guy's. We both run our own nurse-led clinics for patients with MPNs. I'm an independent nurse prescriber as well, so I can see a patient in clinic and prescribe their medication for them. So we have an extra role, as well as being there and being the key person and the point of contact for that patient throughout their journey, from the minute they get their diagnosis or even the workup and they start falling, to the trying to help them back up their stairs. And even when they found their new normal, they were, as we discovered earlier on the survivorship journey, they will still have questions, they will still need support, and we're there for them, basically. So just to recap on some of the psychosocial effects on the person, on the patient and the person. We've covered a lot of these already today, so I'm not going to go into them in too much detail, really. But it's a whole wide range of issues that we need to be picking up on. And also, don't forget, on the other side of this is actually the clinical side, the symptomatical physical side as well of the patient diagnosed with MPN, involving the treatment and the side effects. And then the psychosocial side effects of the psychosocial effects of the carer and the significant other. In some ways, they're reasonably similar, but they're also very, very different. And we've just heard about some of the main issues for carers. So I'm going to start now just trying to give you some examples of patients. So I have renamed them, obviously, and I've tried to use each different stage of the of the picture, really, to try and give you an example of what these are going through. So my first patient is Bradley. He's 27. It was an incidental finding, basically, of splenomegaly and a borderline hemoglobin. Young, fit man. Had some other medical issues in his past, but pretty much well, really. And they were working him up for an operation, and they just found this high hemoglobin, and a physical examination thought, well, your spleen's a bit big, send you to hematology. So he did some reading. He looked at Dr. Google. He looked at causes for splenomegaly and high hemoglobin, and came expecting to have cancer. So he'd already done that. So he came to us in quite a mess, actually, to be honest, psychologically, really very stressed, full of fear, and a lot of mistrust for us as well, actually. He doesn't really believe in medicine. His mother doesn't believe in medicine, doesn't believe in pharma. You shouldn't trust any of those. Just come home, just ignore it, it'll all be fine. Okay. We're still at the pre-diagnosis stage with this young man. We're getting a little bit further along with him, but he still has a lot of these issues. And one of the biggest issues that he had when I sat with him in clinic a couple of weeks ago, and I had to take him out of the doctor consult, I had to take him into my own room, and I ended up spending an hour with him just trying to help him work through these issues, is this complete and utter anger with himself, that he's fine, he looks fine, he feels fine, he goes to the gym, he works out. What is going on inside him? And he's furious. Absolutely furious. And then you've got the family, and they're not interested. They don't want to know. So he has got no one. He had a partner, and he has a 3-year-old daughter, but she's left. She's left him because he is having such an issue with this pre-diagnosis. That's pretty powerful. That's really powerful. So what am I trying to do to support this young man? Listen. Number one thing, listen. Try and understand where he's coming from, what is going on with him, where's he got these ideas from, what's his issue, what is his background, why is he so cross with himself. Once you get an idea of that, you can try and just work out, what you're going to do to help him. Try and give him some information, try and educate him as much as he's prepared to listen to. Empathise with him. Keep that contact and support going. Just every so often, quick ring. Hi, it's just me. You okay? Just checking you're going to come to your appointment. Any other questions? Encourage him to bring his family. Hasn't worked so far, but we can only keep encouraging. and encourage him to speak to and engage with our psychology team. We did have a bit of a breakthrough with that. He has now discussed with our psychologist. They gave him a ring and he's agreed to have a session with them. And actually, one of the most important things with this man is, I completely and utterly, he's out of my league. He's got a lot of psychological issues there that I, as a nurse, cannot manage. And therefore, it's down to me to refer him on to the people that can help him best. And also to encourage him to carry on with his lifestyle. Carry on going to the gym. It's fine, you don't have to stop that. Next patient. Patient, a 65-year-old lady who we diagnosed and have started treatment with PV. She was found because she had a stroke. She made a full recovery, but obviously while she was in, they found that she had high counts. She's got a history of anxiety. We had to reduce her work hours. She's got financial implications going on because she reduced her work hours because of the stroke, but also because of the cancer diagnosis. It reduced her self-esteem. She really struggled with it. She felt, because of a change of her identity, she didn't want to go out with her friends anymore. She'd now turned herself into a person with cancer, not Jane. So that caused social issues. However, she did have a supportive friend who was her main source of support, so we could categorise her as a carer. And she's an oncology nurse, which was great, because she really helped to ground her. And then also she had a lot of anxiety about the treatment, which was hydroxycarbamide, which is a chemotherapy, so it confirmed the cancer diagnosis. So what did we do? Spent a lot of time with her in clinic, reassuring her that it's okay to be feeling like this. This reaction to being told that you have a cancer is normal, okay? We would expect this from everybody. You're not being any different. You're not being weird. This is what we would expect. This is a life-changing situation. And it's really important to tell people that their reactions are okay. There's nothing wrong with the way that you are acting, okay? Referred us to some patient support groups as well, and we gave her the information for the online support group just to let her know she's not on her own out there, and she can actually see that there are other people who are also the same as her, the same age as her, on the same treatment as her, who are doing very well, thank you very much. We wrote some supportive letters to work, try and get her through this initial phase of being very anxious and worried. And encouraged her to get back to her normal activities, go back to her sewing class, continue to book that holiday that she desperately wanted. And then again, an ongoing presence, just checking in every so often. And she's gone on her holiday, which is great. So we helped her to create a new path, and she's doing good. But she might drop me an occasional email, just a little query here, there, another, and it takes 2 minutes to fire back an email to her, and off she goes again, and she's very happy. This is the patient, the wife of a patient. He's 48 years old, he's got myelofibrosis, and he is quite symptomatic, and he's quite fatigued, but he's still working. He looks quite pale. I think if you saw him, you'd think he wasn't that well, but he's working. He's working as a delivery driver, actually. But there was a lot of issues going on, really sort of, that I picked up that was going with this. And you could see it in the console. You can see as the person sitting back and watching the doctor and the carer, and you can actually see what's going on, see the dynamics, and picked up quite early on that actually she was really struggling. Problems with the intimacy between their relationship. They haven't told their children, obviously working, but there are financial issues because he has cut down his work hours a bit, but also she's worried in the future about their situations. She's feeling a little bit more isolated. He's got cancer, and so they don't go out because, he's also very tired. We're worried about their holiday as well. And then she's also got the personal issues. She's that carer who's, struggling, trying to be normal, but actually she's got the guilt. Why him, not me? She's lost the control over him and his disease. This is the lady that controls everything. She controls the house. She can't control what's happening with her husband. And like I said, their holiday. Sent them to Macmillan to get some financial advice, probably more advice now for the future, just to give them some reassurance that it's okay, in the future. Encouraged her to go back and try and go out as she can with her. Also use her friends as some social support to try and restart her activities. It's okay if her husband... And, we had this discussion with him and he gave her permission. So, just trying to reinforce... Try to explore a little bit more about these feelings of helplessness and guilt. Her parents both died of cancer. She's got a past history with cancer, so she's bringing baggage already with her. In our health psychology team, and they are doing joint sessions with the husband and the wife together. We're also doing separate sessions for the wife as well. The husband currently feels that he's okay. The offer is there for him as and when he's ready. And we explored a little bit more about the children, telling the children we can't persuade them to, but then also, it might be worth just letting the school happening, just in case Daddy becomes very unwell quickly, so if you don't want to tell the children, that's your choice, people aware around them. And we encouraged her to see her GP, just to bring the GP into it a bit, so the GP's a bit more struggling as well as he is. Next patient. This is Amir. I'm very fond of Amir. I've known him for quite a while now. He's a 23-year-old young dude, basically. Unfortunately, he's got polycythemia vera, and he was actually diagnosed with a portal vein thrombosis, very young, very young. He, as obviously, we live in London, it's multicultural. He comes, his ethnic background, he's a young Muslim. His dad's got 2 wives, so he lives in a house with lots and lots of siblings as well. Just to give you a bit of background on him. His issues, fear. He's absolutely terrified. He's terrified he's going to die. He thinks he's going to die in about 5 years. So there's no point carrying on. There's no point in me going to college. What's the point in getting a career when I'm not going to be here? So that's fueling, obviously, his low mood and his depression. There's no point getting a job, is there really? What's the point? I mean, I might as well sit at home. So he's questioning his mortality a lot. He's isolated himself socially, although he's also... started smoking cannabis just to try and chill him out and help relax him. His self-esteem is rock bottom. Education, as I said, why bother? I can't concentrate, I'm not going to be alive, what's the point really? Because he's not working, he's skint. I'm not sure where he gets the money for his cannabis from. That's something that we've wondered. Anyway, multiple hospital appointments, 23-year-old kid, even if he wanted to go to work, he's backwards and forwards, with his hospital appointments. He was on warfarin, he was on warfarin. So he was having to go every week to get his bloods checked. Then he was coming to see us as well. There's a lot going on, and every time you go to hospital, it's a reminder, isn't it? His culture, as I said, he comes from a different cultural background. The men are very sturdy. Their problems, they keep it inside. They internalise it. They don't share it. And his family, never seen them. He's got one sister who I communicate with, who will come with him. Never seen his parents, don't know anything about them. They've never contacted us. Just one person who is a sister. So what do we do with this young man? It's taken a long time to build up some relationship and trust. I'm a female for a start, and I am white, different to him. Therefore, it does make a difference, especially to this young man, okay? It's taken a little bit while to sort of break down those barriers a bit and just try and get a little bit of a relationship going. We actually shared a joke the other day. I thought I did all right then. Involve the multidisciplinary team. Can't do this on our own. There is absolutely no way this young man is going to, I'm going to help him on my own. So we needed to bring in, other resources. So we brought in, obviously, the consultant. So we sat and had a chat and just said, look, really struggling. So now what we've done is we've put him on a different type of blood thinner. He doesn't need to go to hospital every week now. Simple. That was easy, wasn't it? One less thing for him to worry about. We've also sat down and given him another very strong chat about the fact that you will not die in 5 years. We are expecting you to live a lot longer. And she actually told him that she was expecting him to, potentially see his grandchildren. And you could just see him sitting like this, sat up like that. Body language, amazing. That's just given him the boost that he needed. TYA, that stands for Teenage and Young Adult. So we are very lucky. We have a teenage and young adult cancer service at Guy's, and they are specialists, and they're formed of a specialist nurse, a doctor, social worker, fertility, a dietitian, psychologist, and they're specialist young adult psychologists as well. So we referred him to that team, and so they've also got him now. So, you know, I work very closely with Gavin, who's the TYA nurse, to try and liaise with him and help him. Psychology, as I've just said, we've had to refer him onto psychiatry as well, because there are a lot of other deep-rooted issues with this young man. We've had to go down the fertility route and discuss with him as well. He wasn't very keen on that, so we've backed off a little bit, but, you know, we've put it out there for him. Introduced the social worker as the TYA team, the dietitian, and also brought his sister in with his permission. I'm running out of time. Okay, can I just do one more really quickly? I'm just going to skip through to the last one. I'm sorry, I've completely missed doing some of this. This is really important, this lady. 68-year-old with PV. We diagnosed her 1 year ago, but her husband has terminal metastatic bowel cancer. She's a patient and a carer. Just think about that for 2 minutes. Everything that we've heard today about the issues that patients have and the issues that carer has, she has all in one. Now, she is not the only person like this, and we have to remember there are a lot of people out there that might be patients, but they also might be carers. So she's got all her preconceived ideas of cancer, seeing her husband who's terminal, and then we're telling her that she's got polycythemia vera and we want to give her a chemotherapy for it. Okay, I'm just going to rush through this, it's a shame, but her children, the only person that knows about her diagnosis is her husband. Oh, actually, and her GP. She hasn't told her children, she hasn't told her friends, because she's concentrating on everyone supporting her husband at the moment. So, again, she's another one. You just have to sit and listen. She comes in and she's just all over the place. She doesn't take in anything you say. She can't remember what she's been told about her husband. So just sit, let her listen, let her get it all out, and then you can start talking to her. Completely, constantly repeating everything that you're saying, because she's not taking it in. She's not in a fit state to take it in. She's literally hanging off that cliff. She's got a lot of these feelings of helplessness and guilt. We've introduced health psychology to her. She's not engaged. She's too busy. She hasn't got time, but it's there for her when she's ready. And I've also liaised with her husband's palliative care team with her permission. They know that she's got cancer now. They know that she's struggling herself. And they said to us, that actually, that fits, that explains some of her behaviour. So it's really important that you look at these other people as well and bring them in, and, you know, other healthcare agencies for her husband. And make sure that, you know, I remained present with her as well. So I'm just there if she needs me. Thank you.